Hi, I'm Dr. Jennifer Jackson. I'm a registered nurse and assistant professor in the Faculty of Nursing at the University of Calgary. And this video presents information on quitting smoking among people with type 2 diabetes. So it's part of a project that's an international collaboration. And we looked at how we can support people who are living with type 2 diabetes and enable their smoking cessation. So this is work I have presented at the Psychosocial Aspects of Diabetes conference, and also a different piece of it at the International Nursing Association for Addictions Nurses. And so I wanted to, in the interest of open access to information and education, I wanted to record the presentation and share the findings here too. So I am a small piece of a big project. I did this work as a research assistant when I was at King's College London. This project is led by Maria Duasso of King's College London and Devin Noonan from Duke University. We're also joined by our colleagues Martin McDermott and Haya Abu Ghazel from King's College London. So diabetes and smoking, these are two things that might not on the surface appear to go together, but are very important for care providers to consider when they're working with patients. So we know 15% of people with diabetes also smoke, and that creates additional complexities. So smoking has an impact on your vasculature, diabetes has an impact on your vasculature. And these factors together mean that we need special considerations for this population and things that aren't currently being considered in either the diabetes community or the smoking cessation community. These tend to be siloed, and by having that silo, we're missing specialized interventions that could really support people to do better with their care. So the basis for the study was the COM-B model. This is Professor Susan Michie's work from, I believe, University College London. So the COM-B model is an evidence-based way of understanding behavior. So we look at where the behavior comes from, what types of interventions are known to influence behavior, and then how policies can impact those interventions. So we're really looking at why people are doing things rather than behavior change models of the past of scolding people into wanting to change or things like that. The other thing I like about this is it takes into account the role of how social factors can influence behavior. So as some of my colleagues in sociology will say, choice is an illusion. There are factors that, whether they be from marketing, from technology, from lots of different sectors, that aim to point our attention and thus our behavior all day long, everywhere we go. So rather than say, you know, individual people need to make changes and pull themselves up by the bootstraps, this is a way of saying, how can we understand where behavior comes from and what can we do to positively support people? So I refer you to Susan Michie's work. It's incredible and life-changing when I learned about the model. It finally put some language behind how to effectively support people rather than just repeating the same old patterns. So how do we look at the COM-B model in application towards this specific study? So we looked at COM-B being capability, opportunity, and motivation leads to behavior. So capability, there's physical and psychological capability. So you have to be able to do the thing. So physical referred to, are you aware of the consequences of quitting smoking versus the consequences of continuing to smoke? Psychological, do you have the knowledge, attitude, desire to quit? Is this something you want? Opportunity, So physical opportunity looked at access to nicotine replacement therapy and healthcare professionals. So opportunity saying, can you access the stuff you need to help you make this behavior change? Social looked at the support of family and friends. Are there people around you who would support you to quit smoking? And motivation, saying, why might you want to quit smoking? Or why might you want to continue smoking? So automatic referred to habits that facilitate smoking, whereas reflective was, what are the reasons that people might want to quit, and how could we maybe reflect on those reasons as part of a process of smoking cessation? So in terms of the methods, we did framework analysis using the COM-B model as the framework. So qualitative interviews, we had 20 participants in the USA, 11 in the UK. The majority were female and white, which can be a caveat for applying these findings in different settings. So overall, we found that diabetes services are not meeting people's needs around smoking cessation, and smoking cessation services are not meeting people's needs around diabetes. So there's this catch-22 of, if I quit smoking, I'll gain weight. If I gain weight, it throws off my hemoglobin A1C. But then I have to lose weight to get the hemoglobin A1C in control, which means I take up smoking again. So people felt like they were in this catch-22 where they just couldn't win, and ended up kind of in a paralyzed position of, I can't move anywhere here. Participants also felt significant shame around smoking and addiction, and we'll get into that a little bit more in the coming slides. So the context of this was people experiencing significant diabetes distress and mental health issues. So diabetes distress reflects the distress around the amount of work, the amount of psychosocial impact that is associated with managing diabetes. And there's a broad amount of research on that, and I refer people to the diabetes distress research for more discussion of that. But saying that, so the role of diabetes in someone's psychosocial life is not insignificant. We also found that folks they had significant mental health issues. They also felt like smoking as an addiction was not taken seriously. And so people treated smoking as though it was a choice and that people could quit anytime. However, we know that nicotine and smoking use has one of the highest conversion rates from a casual user to a habitual user, and that it is truly an addictive substance. We've known this for decades now, but somehow at the point of care, it's not getting translated to that smoking is genuinely an addiction. And a lot of our participants felt like the outcomes and the services that were available to them didn't take smoking seriously as an addiction. So they also felt a lot of shame about smoking. They said, I'm a social pariah. I am doing something that's banned and pushed aside, and it made them feel like they were bad people in a lot of cases. So this quote from a participant talks about how these mental health impacts, the diabetes distress, the shame, all kind of layers in and continues to facilitate some of the smoking. And that needs to be taken into account. For any healthcare professionals working with these folks, we need to consider, how do we take the mental load of all of this into account when we're working with these patients. So around capability, all the participants in the study wanted to quit smoking. Every one of them said they wanted to quit. Now, we might have like a self-selecting population of people who say they want to quit and that's why they participated in the research. Either way, they did all want to quit. They felt significant grief, shame, and exclusion socially. They felt like it isolated them from other people, from supports, from activities they wanted to do. However, one of the biggest issues with capability was a concern about weight gain. So thinking back to that catch-22 idea, when you stop smoking, often people gain weight. And they said, well, I can't have any more weight on me, but I need to stop smoking. But if I stop smoking, the weight gain is going to come back. And this was a significant cause of distress for our participants. So one thing we can think about here is that if we're working with people who have diabetes and smoke, maybe we say, okay, the priority is that you quit smoking, so we're going to worry a little bit less about the weight for the next 6 to 8 months. And we'll tolerate a little bit higher hemoglobin A1C because the short-term potential impact of having the higher blood sugars or gaining additional weight will outweigh the benefits, or will be outweighed by the benefits of the long-term quitting smoking. So having those discussions with your patients to say, what are our long-term and big picture goals here, and how can we support you to get there? What kind of trade-offs can we consider acceptable in order to have an overall move towards improving your health? So under opportunity, this is where the demographics of this study really came into play. We saw a huge difference between those in the UK and the US. The UK having a quite comprehensive healthcare service that's free at the point of care, and the US not having the same availability. So folks in the US really struggled to access nicotine replacement therapy. Both groups also talked about the need to replace the experience of smoking. So there were participants who said, I have a child with special needs, I have a parent with early stage dementia, they're both in my house, they are both needing me every moment of every day. The only time I have to myself is the 5 minutes I go out for a cigarette. And I can take some deep breaths and think my own thoughts, and just, it's the only moment I have that's just for me. And I felt terrible for this person. Like I would light the cigarette myself for them in that moment, because how can you say we need to take away smoking and thus take away those few minutes that you have to yourself? So it's looking at how do we replace the experience of smoking, or what smoking gives to you beyond the biochemical process. How can we support that process as well? Also, some people said the use of toothpicks or gum, like they liked having something, there was the oral piece of the process. So they needed nicotine replacement therapy, but also things that helped replicate some of the other parallel benefits they got from smoking. Also, participants reported that they faced significant shame and harm from healthcare professionals, and we need to look at how we can provide those services differently. So like this participant shared, she was scolded and like literally had somebody wag a finger at her. And if somebody did that to me, I would never go back to that clinic, no matter what it was for. So that, I think, leading into motivation, I can understand when you might struggle to access healthcare professionals. When you finally get them, they lack empathy, they don't support your goals, and doing something like waving a finger at you, I mean, no wonder. No wonder. So looking at motivation, people felt that, yeah, smoking was not treated as an addiction. It was not taken seriously as an addiction by healthcare professionals and other people in their lives. So why can't you quit those? And why are you still doing that? And clients or participants talked about, well, there's Alcoholics Anonymous, there's support groups, there's these different types of interventions, and there's nothing like that for smoking. There's no Nicotine Anonymous, there's no nicotine support or discussion groups. And they felt like that further reinforced the stigma of smoking isn't an addiction, it's a moral weakness. Also, in some cases, they said, well, if I stop smoking, I'm going to have more social isolation. Smoking is part of that's what my husband and I do together. It's what my buddies at the pool hall, we all go out back and smoke. And if I'm trying to avoid triggers and avoid smoking, I'm going to cut myself off from my friends and my family or other people that are important to me. And we don't want that outcome for anyone either. So how can we take that into account in terms of their motivation? Participants reported that they had both positive and negative motivations for quitting smoking. So some people wanted to avoid negative consequences, such as things like lung cancer, the physical consequences of the smoking and diabetes. But then also they wanted to have positive motivations like saving money, spending more time with their grandkids, and things like that. So there's a lot of factors in motivation that can tap into how do we work with people to support smoking cessation. So when we assess the need for an intervention, participants told us loud and clear that we need something that's tailored to consider both the smoking and the diabetes, because given the interconnected nature of these two things and how they can play out in the body, we need to take both into account. People wanted group-based quitting programs like a Nicotine Anonymous or something along those lines. They wanted to talk to other people who were going through the same thing and have the support of peers. They wanted validation that smoking is an addiction and it's not just a moral failing or a bad habit. They wanted validation that this is an addiction and how can it be addressed as an addiction. Participants were open to receiving tailored messages via text, and they thought that text message would be one way that they could be supported in an intervention. They liked texts because they were private and not necessarily everybody would know about it. There was a preference for positive supportive messages. So they did not want another picture of a black, horrible lung. They said, like, we've seen that picture, it reinforces the stigma, it reinforces the shame. Instead, what I want is something like, here's a tip that can help you towards your success. They wanted positive messages and things that supported them towards their goals. So looking at next steps, we saw there's a need for a specialized customizable intervention that was specific to the context of smoking and diabetes. Also needed to take into account things like weight gain, stress management, the social aspects of smoking, and the need to recognize smoking as an addiction. Finally, we also need to consider system barriers. A lot of the folks couldn't access nicotine replacement therapy because of cost or other things like that. And we set people up to fail if we say, okay, you need to use nicotine replacement therapy, but it's not accessible. So those are all things we need to think about as we go forward. So huge thanks to my colleagues who supported this study, and it was very eye-opening for me, and I realized how much stigma towards these people I carried with me before I did this research. So I'm hoping that other people will also have a different perspective after becoming more aware of this study, and that we can use that different perspective to support clients to their preferred outcomes. So thank you very much.